Good afternoon. I'm Charlene Gavel, and we did RPIW number 4. This is our agenda for our next 20 minutes. This is the picture of our fabulous team that we worked with on RPIW number 4, which is in the adult inpatient mental health unit. If you haven't noticed, Brent's very tall. Our project was to create a standard care process to eliminate discharge delays. So looking at some of the current situation, our standard length of stay is much higher than the High national average. So we were looking at how we could reduce that length of stay. So our goal was to develop a standard care process for patients on the adult inpatient mental health unit from the time of admission to the time of discharge. This is the value stream map that was completed by a team that did the value stream mapping at the end of June. So they took a look at what the patient process or the patient flow for that day. So if you look, there's lots of Kaizen bursts on this value stream map. We actually addressed many of them throughout this RPIW week. The key one that we addressed, though, is this one, and it's patient-specific care plan and goals daily. So that was really the focus, but lots of those Kaizen bursts have been addressed. So what were our targets for the week? Well, we wanted to reduce space, inventory, distance traveled, length of stay. We want to ensure that there's a countermeasure or a quality measure related to that, so that's readmissions, and get some productivity gains. So we have a baseline and we have the targets. So the takt time for our process is related to the time available in nursing work. So looking at the shifts, there's about 2,700 minutes available, given how many nurses work on that unit, to give patient care. Some of the data that we used to look at where we wanted to focus our efforts and what was going on, we looked at what the top admissions are over a year. So those are the top 4 admissions to that unit. We also looked at length of stay. So this one is very interesting. You'll see that there's lots of outliers here. So we have an average length of stay, some stay shorter, but there's a significant portion of the population or the admissions that do stay significant lengths of time. And this is another graph depicting similar data. So I'm going to hand it off to Brent for Kaizen theme number 1.
Thank you. Good afternoon. I'm Brent Kitchen. I was sub-team lead for RPIW number 4. I was the lead on Kaizen theme number 1, which is create standard care process to eliminate discharge delays. So our work on that theme really began when we mapped the current state and created our value stream map. And during that mapping process, we identified that the actual average length of stay for patients on the unit was 19.6 days, which exceeded the High national average, which was 13.5 days. We also observed some other issues that we thought were key and perhaps causing that extended length of stay. We identified that care plans were being developed, but often barriers to discharge were not being identified and acted upon until later in the admission, often when the team was actually contemplating discharge. The D system was relatively new on the unit, but it didn't appear to be fully utilized in the way it's intended, and the targeted date of discharge was not always identified. We also observed that members of the team were waiting for referrals among team members, which was causing delays, and we also observed that patients didn't appear to be continuously engaged in their care planning as part of the recovery module that's advocated on the unit. We also saw lots of forms and charting required. We also noticed what was likely a lack of standard work. When we did look at the barriers to discharge, they often fell into 4 general areas, those being placement or housing issues for patients, just the patient's readiness, which perhaps was a reflection of how engaged they were in their care planning process. We identified orders and referrals between team members that were required, And we also identified funding. So these are some of the things that some members of the team can help address during the patient's stay in the unit and help identify early. So these ideas really framed our vision for the future state and our Kaizen ideas.
Good afternoon. My name is Jan Bessie. The future state was mapped in week -3, and 4 Kaizen ideas were generated. The first Kaizen idea was to reduce the length of stay by 4 days, and that was done through identifying targeted day of discharge predictors, as well as looking at the average lengths of stay for different conditions at this point. The second was to develop a new care plan. The third was to look at developing standard methods for rounds meetings. And the fourth was developing standard work for prior to discharge on days D -3, 2, and 1. And so the decision was made to focus on processes around reducing the length of stay, developing a new care plan, and trialing standard work for prior to discharge.
Hi, I'm Jessica Murphy. The process was to complete a new care plan discharge checklist. This new care plan will be completed within 24 hours and reviewed daily by the patient's primary nurse. This will engage the patient more actively in their own recovery and help them plan for their own discharge. Another significant change that we made was referrals to social work, occupational therapy, addictions, and pharmacy. Nursing and any other member of the multidisciplinary team can now refer to these team members. Previously, referrals had to have a physician's order, and referrals were often delayed. This will also reduce duplication of documentation for nursing and releases time to staff to provide care for patients.
Good afternoon. My name is Lori Lennon. This is the actual discharge care plan checklist, as well as just the patient's care plan that we had developed throughout this week. Based on the barriers to discharge, we developed certain care need areas that we're going to be looking at. It has a one right place for the targeted date of discharge, so we're not looking for where that discharge date is. With the care needs, it allows us to identify what the concern is, what the barrier to discharge is, what actions we've taken, and once we've eliminated that barrier, we'll put the date that it's completed. On the bottom part of the second page of the form, we go into the specific areas that tend to have problems with discharge planning. So just encourages the staff and makes the staff aware of the proper things that they need to do so that the patient can be appropriately discharged. And this is one of the really important parts of the form, just because it gets into the actual standard process of the D system and looking at D-3, D-2, D-1, making sure that we eliminate any barriers that may happen so that the patients can be discharged home on D-Day. And this is also where we'll be doing all of our interventions. Will be written from every single discipline, and it will be chronological order so they don't have to look in numerous places in the chart.
Hi, my name is Jan Johnson. This new care plan, a discharge checklist, reduces the volume of charting by nurses and decreases the number of forms in patients' charts. The multidisciplinary care plan replaces 5 current forms: the needs assessment record of care, the individual care plans, which there are 18, multidisciplinary team meeting forms, ward rounds worksheet, and the D system worksheet. Not all of these forms will be used in every chart. However, you can see that the choice of forms and the sheer volume of paper is greatly reduced. We've decreased the forms from around 20 to one 4-page multidisciplinary form. In order to ensure that this care plan is implemented and that staff understand how to use it, we've created a formal implementation plan, a training plan, and a multi-skill training checklist.
Thanks. Good afternoon, I'm Rochelle Hahn, and I'm coming off a fantastic, fun-filled week. We had a really, really great week. So I'm going to be speaking on the pre-Kaizen work that we were doing. Our focus was looking at reducing the cycle time of the nursing daily routine. So it started by gathering the information needed. Observations were done on a nurse's daily routine from 7 a.m. to 11 a.m. By observation and data gathered, a nurse's routine basically cycles every 4 hours. So based on that 4 hours, we summarized what the nursing does into 9 categories as it is depicted on the standard work combination sheet. As you can see, a lot of time is spent at the nursing station charting, as well as preparing and dispensing medications. The following are 2 spaghetti diagrams. We timed and followed the nurse on where they go on both the east and west sides of the unit. On observation, in those 4 hours, with the nurse having a pedometer on her, she walked 1,547 steps. Another way to look at the daily nursing routine on both the east and west sides is by doing a percentage load chart. As you can see by this chart, there's a large amount of time spent on charting and on medications. What the team decided to look at is decreasing the time spent at the nursing station charting, as well as preparing and dispensing medications, with the goal of increasing time spent with their patients.